Hello everyone, I'm Nicolas Mottet, a French urologist based close to Lyon, and I'm the current chairman of the EAU Guidelines on prostate cancer. Okay, M1 disease means any part of disease outside the pelvis and the prostate. It can be stratified in three groups: M1A, which is disease in the retroperitoneal nodes; M1B, which is disease in the bone; and M1C, which is disease in the visceral, that is liver and lung. These are the definition of M1 disease as a whole, and the definition is based on old-fashioned imaging, that is bone scan and CT scan, and even MRI, whole body MRI. If you use PET PSMA, the most sensitive way to assess the extent of the disease, we have absolutely no data to support its use in terms of outcome. All the data, again, are based on bone scan and CT scan. Okay, intensification of treatment in N1 M0 disease means disease that is purely in the pelvic nodes. And so far, there is no evidence that anything on top of a local treatment plus a systemic with ADT is better and adds anything outside toxicity. So it shouldn't be considered for N1 disease. And I insist, N1 means disease in the pelvis. If it's a retroperitoneum, it's M1A. Well, the ideal treatment for M1 disease doesn't exist. If you want me to simplify the answer, it's ADT plus something. ADT monotherapy should be clearly considered as an undertreatment and should be reserved to patients that are unable and unwilling to receive anything on top of ADT. The question is, what is the something else? It might be an ARTA, that is ABI, ENZA, ARPA, or DARO. It might be chemo with docetaxel. And the best choice is still unclear. It has to be based on patient's preference, patient's ability to receive the requested drug, that is mainly based on comorbidities. It has to be based on drug availability. And on top of this systemic treatment, combined with ADT, there's another option, which is prostate radiotherapy combined with ADT. The key question is, how do we choose between a combined systemic treatment or a prostate radiotherapy plus ADT? We don't know yet. The next question might be, do we need to combine prostate radiotherapy with a combined systemic treatment? And the answer is unknown. The PEACE-1 trial might answer this question, but so far it's either ADT plus radiotherapy to the prostate or ADT plus a systemic treatment on top of it. The best choice is not evidence-based, but has to be discussed with the patient. Well, the key message is that most trials dealing with M1 disease included a majority of newly diagnosed disease. So all the trials had a majority, and one trial, the Latitude trial, had only newly diagnosed, 100% newly diagnosed. It means that the best evidence is there for newly diagnosed disease. Regarding those who relapse, we know, at least from retrospective database, that the outcome seems to be a little bit better compared to the outcome on patients that were newly diagnosed. If you consider all the trials as a whole, there is no rationale to say drug A or drug B or drug C is better. So if you consider all the trials as a whole, it might be either an ARTA or chemotherapy. There is no rationale to select one or the other. The key question is when to use a combined treatment at relapse. And again, the evidence is not so clear. It doesn't mean it has no role. It just means that we have to individualize. And outside guidelines, probably it's wise to say if you relapse in metastatic situation very quickly after the local treatment is finished, probably you were already metastatic. On the opposite, if you relapse several years or many years after the local treatment is finished, probably the disease is a little bit different. But the best treatment remain to be clearly proven, and the best treatment choice remain completely unknown. Let's clarify. Uh, in guidelines, we never use purely presented material. It has to be fully published. One of the fully published material that was supposed to be presented at EAU is the randomized controlled trial by Hoffman in upfront staging for high-risk disease with PET PSMA. It's already fully published in European Urology. We had at least 2 or 3 editorials discussing this point. So I'm quite sure this will be in the next upcoming data and in the upcoming guidelines. All the rest has to be published. If it's not, we do not allow this to be in because the peer review process is absolutely mandatory before we can consider anything to change the guidelines.